Welcome to Psydactic, Child and Adolescent Psychiatry Edition. I am your host, Dr. O'Leary, a fellow in child and adolescent psychiatry in the National Capital Region. I started this podcast to help me study for the boards, and I hope it helps you with why ever you are listening to this podcast. Every time I do an episode, I try to let everyone know that everything I say here is my own opinion and no one else's. I also use AI to assist me with the content creation. Specifically, I use Gemini's deep research tool, and sometimes I use Notebook LM as well. These help me to find sources, in addition to sources that I'm already looking at. It helps to consolidate them together, and then to create an outline of what it is that I'm going to present here. I use my own background knowledge as well as I spot check the facts the AI comes up with just to make sure it's not making stuff up. But making mistakes is not something that is unique to AI. Humans do it as well, so I don't see it as a unique feature of using AI. This is part 3 of a 3-part series on trauma and stressor-related disorders in the pediatric population. Part 1 focused on the diagnosis of things like PTSD, acute stress disorder, reactive attachment disorder, and disinhibited social engagement disorder. Part 2 focused on the epidemiology and the etiology and neurobiology of these disorders. This episode is going to focus on treatment of these disorders. And for treatment of trauma disorders, the place to start is always therapy. When kids experience trauma or severe stress, there are many different ways that we can help them. But the best approaches depend on what kind of issues they are facing, their age, what the specific trauma was, and then also any other conditions that they might have. So for most kids dealing with trauma and stressor-related problems, especially PTSD, talk therapy is usually the first step. And there are some well-established evidence-based therapies out there. The first is a trauma-focused cognitive behavioral therapy. Trauma-focused CBT is a well-structured therapy that's been shown to be very effective for children and teenagers, ages all the way from 3 to 18. It was originally developed by Judith Cohen, Anthony Manarino, and Esther Deblinger. I think I said those right. So the main part of trauma-focused CBT can be remembered with the acronym PRACTICE with 2 P's. The first P is psychoeducation, and the second is parenting skills. So this means basically teaching both the child and their parent or their caregiver about trauma and its effects, and then help the parents to improve their strategies at working with the child, because the child's going to be going home with the parent, and if the parent can learn ways to help the child to cope, that's going to support the child's recovery. The R in practice is relaxation skills. So kids learn ways to calm their bodies, things like deep breathing, progressive muscle relaxation. The A is affective expression and modulation. So this teaches kids that it's okay to show their emotions. It helps them to understand them so that they can better manage their feelings. So that's affective expression and modulation. The C in practice is cognitive coping and cognitive processing. Kids learn to identify unhelpful, messy thoughts about the trauma and then to change them or to question them. So that's cognitive coping and cognitive processing. The T is the trauma narrative. Gradually, the child can create a story. It can be verbal, it can be written, it can be played out about what happened to them. And this can help them to process their thoughts and feelings and really make sense of it. The T in practice is the trauma narrative. The I is in vivo exposure. And this is generally a gradual exposure and involves slowly helping the child face situations or reminders related to the trauma, things that they sense now are scary, but are actually safe. The second C in practice is conjoint child-parent sessions. So these sessions help the child and the parent to talk about the trauma together and helps to build a relationship that's supportive between the parent and the child. And finally, the E in practice is enhancing future safety and development. So creating safety plans and encouraging resilience and healthy growth. So trauma-focused CBT typically involves anywhere from 8 to up to 25 sessions, and it works well for different types of trauma because it's very easy to apply broadly. And it also helps across different ages as long as you're using age-appropriate methods. And it can even be used across different cultures. It's recognized by the Substance Abuse and Mental Health Services Administration as helpful therapy. And even if a child doesn't have a formal PTSD diagnosis, they could still benefit from trauma-focused CBT if they're having some trauma-related symptoms that don't quite meet criteria, but are causing some distress or dysfunction in their life. Another therapy that incorporates a broad set of different methods is eye movement desensitization and reprocessing, or EMDR, which is a lot easier to say. EMDR was created by Francine Shapiro, and it's been shown to help with PTSD in adults, in teens, and also in children. The World Health Organization and the International Society for Trauma Stress Studies suggest EMDR for kids and teens with PTSD. This therapy has 8 basic steps and involves bilateral stimulation, things like following a light with your eyes, listening to alternative sounds, or even tapping, while the person thinks about their traumatic memories, thoughts, feelings, and body sensation. So the idea kind of behind this is that memories can get stuck, that you don't have this extinction of the memories that you normally would have, or this full processing of it. And EMDR is thought to help unstick the memory, help them to be less distressed when that memory comes up, and develop healthier ways of dealing with things. It's unclear that the eye movements themselves really have anything to do with it. There's other things that you can do similar to eye movements, but the process of the child maintaining their attention on something that they are doing while they are processing their trauma at the same time helps them to unstick themselves. EMDR can be adjusted for kids of different ages, and it's been used on kids even as young as 2. You just have to change the procedures that you're doing to fit the developmental stage. It's effective for reducing PTSD in children who have single traumatic events or who have had ongoing or complex traumas, things like recurrent sexual abuse. EMDR can work pretty well. It often works as well as CBT, and it even incorporates a lot of CBT principles into it. So it's not really a separate thing. It's just a different method of doing CBT that also involves doing some sort of sensory motor focused activity. So while trauma-focused CBT has been shown to be a little more effective than EMDR, both are good treatments for kids with PTSD. And if one doesn't work, you can try the other. EMDR might also act more quickly. So if you have less time to do therapy, EMDR might be favored over trauma-focused CBT. So that's PTSD, the main things to do for PTSD, some sort of CBT, cognitive type reprocessing therapies, or EMDR. But for the attachment-based disorders like reactive attachment disorder and disinhibited social engagement disorder, there needs to be a different approach. So since these 2 disorders usually come from severe early neglect, maybe along with some trauma, problems with caregiving, the main goal of the treatment for these disorders is to improve the relationship between the child and their caregiver, creating a stable caring environment and helping them to develop later than they normally would some kind of effective attachment toward others. So one of the therapies is called Attachment and Biobehavioral Catch-up, or ABC, and it's generally used for reactive attachment disorder. It was developed by Mary Dozier and her team. So ABC takes about 10 sessions. It's a home visit program, and it's specifically for infants and young children, usually between 6 to 24 months. There's a toddler version that goes up to 48 months who have experienced early hardships like neglect or inconsistent, unreliable care and are at high risk for reactive attachment disorder. So ABC focuses on 3 parenting behaviors. First, nurturing. Be nurturing to the child even when they're not seeking it out. Approach the child, nurture them, show them love, kindness, say nice things. The second one is following the child's lead to help them feel connected and to regulate themselves. And third is avoiding scary or intrusive parental behaviors. So parental coaches will give immediate feedback and support to parents as they're interacting with children. This is similar to PCIT. And a lot of studies show that ABC really helps parents to be more sensitive, increases the secure attachment that the children can develop with them, improves the child's self-regulation, better sleep-wake patterns, better executive functioning, more stable and on-target language development. ABC is a program that targets the core relationship problems that result in reactive attachment disorder. There's also caregiver-focused help for disinhibited social engagement disorder. There aren't as many structured programs specifically for disinhibited social engagement disorder as there are for reactive attachment disorder, but there's some research, especially from the Bucharest Early Intervention Project, and it highlights the importance of the caregiving environment. The Bucharest Early Intervention Project showed that placing young children who had experienced severe early institutional deprivation into good, supportive foster care was much more effective than keeping them in institutions. So putting them into homes was better than improving the institution. This works both for disinhibited social engagement disorder and for reactive attachment disorder. If the child is placed into a stable, caring, and permanent family environment, the earlier they're placed there, the better. These interventions focus on things like avoiding frequent changes in caregivers, because this can make the disinhibited social engagement even worse. So anything you can do to provide consistent, responsive care where there are clear boundaries and social norms and help to guide children very explicitly, teaching them social skills within a secure relationship that is there over the long term. So the common thread in effective treatments for reactive attachment disorder or disinhibited social engagement disorder is to improve the quality, consistency, and responsiveness of the caregiver and care receiver relationship. It gives the child a chance to experience the kind of care, the kind of environment that they have to have for healthy social and emotional growth. Now, while I'm on the topic of trauma and neglect, I want to discuss briefly something called the neurosequential model of therapeutics. If you've ever read the book The Boy Who Was Raised as a Dog by Dr. Bruce Perry, he developed this, what is really a clinical approach more than it is a treatment. And it is supposed to be a developmentally sensitive, biologically informed approach to clinical problem solving when you're doing treatments. So it's not necessarily a technique, but more of a framework to follow. So NMT provides a way to kind of organize the child's history, including their developmental and trauma histories, and then to assess their current functioning, and integrates principles of neurodevelopment and traumatology to try to create a holistic picture of what a child's needs might be. Next, they do some brain mapping. So this is where an NMT certified clinician conducts a comprehensive assessment of the child's developmental history and their current functioning. And then they use this to generate an NMT metric report, which includes something they call a functional brain map. And this map is supposed to help to identify areas of the brain that might be underdeveloped or functioning poorly due to the impact of trauma and stress. And once you have this map, then you can develop what are called sequenced and individualized interventions to target things. And this can be therapeutic, educational, or just enrichment activities. But the goal is to apply the interventions in a certain way and sequence that matches a child's specific neurological needs. They want to target first the lower, sort of less complex parts of the brain before moving up to the more kind of complex relational and cognitive therapies that would ostensibly happen more in the cortex. So start with regulation of the brainstem and then move up to the cortex. This is not a highly recommended therapy by groups, and for a number of reasons. I think one of them is it's kind of difficult to implement and resource intense. And another one is that hasn't necessarily been shown to be any better than anything else. There's some evidence that it can be effective in certain populations, but it being so resource intense, you have to do lots of training in order to do it right. It's not as adaptable to the kinds of institutions that are out there right now. I doubt it's going to be tested on the boards. When it comes to things like acute stress disorder and adjustment disorder, we were going to return to a CBT based model. And what's important with acute stress disorder and adjustment disorders is that the CBT is given early as possible, as soon as it is identified that the child is having difficulties, some sort of CBT intervention. So this could include, and usually starts with, and should start with, some sort of psychoeducation, teaching about trauma, helping them to manage their anxiety about it, talking to them about their symptoms so that they know that this is something that people experience after trauma. They're not strange or different. They're just a human being having human feelings, and then helping to cope and manage with those feelings. And if you can do that early, you may be able to prevent the onset of PTSD. And with adjustment disorders, it's similarly when a child is trying to adjust to a new situation and it's very difficult, the earlier you can orient them toward techniques that are going to help them to both cognitively and emotionally adjust to the situation, the better they're going to do in the long term, and the more their behaviors are going to align with actions that promote resilience instead of making their life harder on them. So to kind of summarize, for PTSD, we have trauma-focused CBT and EMDR that is often recommended. For reactive attachment disorder, you might think ABC, which is Attachment and Biobehavioral Catch-up. And for disinhibited social engagement disorder, you really want to focus on the child's environment, having good foster care, family-based help, making sure the child's in a stable, caring family, and train the parents to support the child and avoid moving them around a lot. For adjustment disorders, you need supportive therapy, psychoeducation, and CBT. And that's similar for acute stress disorder. You need a trauma-focused approach to CBT that happens as soon as possible. Now, I can't end a discussion about therapy for trauma without talking about pharmacotherapies. And really, there are not that many out there that have a large evidence base for trauma, or specifically, they're approved by the FDA, and none of them are approved by the FDA in pediatric populations. So we have things like Zoloft and paroxetine that are FDA approved for adults, but this doesn't extend to the pediatric population. So what prescribers tend to do for symptoms that aren't fully responsive to therapy or that are so intense that they need to have some symptom control before they can meaningfully participate in therapy, we may try to target things like their anxiety or the depressive symptoms. So for pediatric depression, Prozac and Lexapro are both approved. For anxiety, generalized anxiety, social anxiety, duloxetine is approved in children. SSRIs like Prozac and Lexapro and Zoloft and Luvox all can be helpful. And those are approved for pediatric OCD. So in general, you could say that selective serotonin reuptake inhibitors are commonly used as first-line pharmacological adjunctive agents for PTSD, but not as the primary treatment alone. In some cases, you can also use alpha-2 adrenergic agonists, things like clonidine and guanfacine, especially for symptoms like hyperarousal or nightmares, aggression, instead of reaching for an antipsychotic first. And for sleep disturbances, because they can be very helpful with sleep. For some children, they're pretty sedating. But the problem is sometimes for children, they're way over sedating. So something like Intuniv or long-acting type guanfacine might make a child sleepy throughout the whole day, which isn't helpful. So you might want to go with something shorter acting like clonidine before they go to bed to help them sleep, or to help to control their autonomic symptoms during the day. Now, for acute stress disorder, it'd be interesting. I'm going to talk a little bit later about that, but there's really not a huge role for medication in that setting. And benzodiazepines are sometimes used, but I'll get back to those. For adjustment disorders, medication is not the first line, therapy is the first line. And you can, if they have some severe symptoms or they have some underlying anxiety in general and things are getting a lot worse, and you think maybe they could benefit from some adjunctive treatment, you could try that. But the place to start is really with psychotherapy for acute stress disorder and for adjustment disorder. And then there are no pharmacological therapies out there specifically for reactive attachment disorder and disinhibited social engagement disorder. So the only thing you would use medications for is to target certain things, like if there's severe anxiety, if there's depression, or if there were significant behavioral issues like aggression, you might reach for some medication, especially like an alpha-2 agonist. Now let me talk then about benzodiazepines, because they have a very limited and really specific role in pediatric populations, because their risk-benefit profile is not very favorable. So meta-analyses have shown that benzodiazepines can be effective and generally well tolerated for very short-term anxiolytic activity and procedural anxiety in children. So just before like dental work or some minor medical procedures that are highly distressing. But current practice guidelines do not recommend benzodiazepines for acute or ongoing management of anxiety, including that related to trauma or traumatic stress in pediatric populations. And the VA DoD clinical practice guidelines for adults recommend against the use of benzodiazepines for the treatment of PTSD. Now I want to talk about antipsychotics because I think a lot of kids with trauma histories, especially those that who have experienced a lot of neglect and who have huge tantrums when they are trying to get their needs met, often get antipsychotics first line. Because antipsychotics have been approved, especially risperidone and Abilify, for aggression in autism, and a lot of the kids who have experienced trauma end up having a lot of aggressive behaviors or just severe irritability. But antipsychotics do not have any benefit in treating trauma. In fact, they may worsen trauma. They certainly do not help children to heal from trauma and should be rarely ever used, except maybe in some pretty extreme circumstances to control symptoms that are likely the result of trauma in children. And besides that, the use of antipsychotics, especially for the long term, have significant adverse effects, especially metabolic side effects that can be a lot worse in children, things like weight gain, hyperglycemia, dyslipidemia, hyperprolactinemia. They're often sedating, they can cause drowsiness. Rarely, for the second generation antipsychotics, extrapyramidal symptoms, dystonias, movement disorders, and if they're on there for quite some time, tardive dyskinesia. So the overall message here is there are no approved medications to treat trauma symptoms in children. If you're going to give medication with kids who have PTSD, it's not going to be to treat the trauma. It's going to be to treat a particular cluster of symptoms. And usually some comorbid condition in the PTSD, like if they also meet criteria for major depressive disorder or generalized anxiety disorder or a social anxiety disorder. Think therapy first. Avoid benzodiazepines, avoid second generation antipsychotics unless you've tried everything else already. And for aggression and behavioral issues, start with alpha agonists first before thinking about the antipsychotics. And especially therapy. Therapy, 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 therapy. Thanks for hanging in with me today. This has been the third and final episode in a three-part series about pediatric trauma. There's a lot more that could be said about this, of course, but this is where I'm going to draw the line and move on to something else. If you would like to leave me any feedback, you can go to psydactic.com and there's a feedback form there. These episodes also are released on YouTube. So if you listen to it on YouTube, you can leave comments in the comment section there. You can also just send an email to feedback@psydactic.com, and I'll try to get around to responding to you. But in the meantime, take care of yourselves. I hope this has been helpful to you. I am Dr. O'Leary, and this has been an episode of Psydactic, Child and Adolescent Psychiatry Edition. Nothing in this podcast should be considered personal, medical, or mental health advice.